soon with our first speaker. He is Professor Medhat El-Sahhar. He is a professor of hepatology and gastroenterology in the police authority hospitals, and he is a very, very elegant speaker and very enjoyable to follow. And his lecture is about a very, very important message that we want to convey from the messages of this session is the clinical approach to a patient with diabetic gastroparesis. Okay, the floor is yours, Professor Medhat.
Thank you, Professor Mohammed. Thank you, Professor Ines, for your invitation. When a patient comes to a GIT clinic and he has diabetes, the gastroenterologist has to interpret the symptoms of the patient in the background of being a diabetic patient. Our speech today will be about gastroparesis. Gastroparesis, it is a motility disorder. It is characterized by symptoms and objective documentation of delayed gastric emptying without mechanical obstruction. So this is the definition of it. There is delaying gastric emptying without mechanical obstruction. All of us know that the stomach, two parts, the fundus and the body, they accommodate the food, mix it, and then the antrum will pass these small particles to the duodenum. The fundus exerts a pressure to push the food. If this motility is not good, many of the food will remain. Usually, after 4 hours, 90% of the food in our stomach has to pass to the duodenum. If there is more than 10% in our stomach, this means delayed gastric emptying. So this is our point today. Many etiologies lead to this, either GIT problems or non-GIT problems. However, in all the series, the most important 3 causes are idiopathic, diabetic, and post-surgical. So gastroparesis, diabetes, about 1/3 of the patient coming to our clinic with manifestation of gastroparesis will have diabetes. It is classically considered in long-standing uncontrolled type 1 diabetes that have also retinopathy, nephropathy, and the peripheral neuropathy. And many of these, in a study, the prevalence of gastroparesis was found to be 5% in type 1 diabetes and 1% in type 2. So 5% of our patients with type 1 diabetes will have this problem. Pathogenesis is not known. Till now, many theories. And this, for me as a clinician, I will not bother myself with it. This is in the research way. But actually, what is the cause? Till now, the pathology, the pathogenesis is still not fully elucidated. The patient usually, when he comes to the clinic, he has mainly 5 symptoms. Nausea, 92%, then vomiting, early satiety, postprandial fullness, and the upper abdominal pain. These 5 symptoms are very usual symptoms and complaints in any GIT clinic. But in a patient with diabetes, and especially type 1, I have to interpret them that they may be a gastroparesis in these patients. Patient may experience any combination of these symptoms. He means nausea and vomiting, nausea and bloating. And usually the symptoms are often chronic, and they have exacerbation. They increase and decrease. And they will affect the health-related quality of life. And even they may reach a point that the patient will be malnourished. Symptoms begin usually later in type 2, but in type 1 it begins earlier. And 14% they found that gastroparesis may start after an infection in the GIT. There is a score that we can know the severity of these symptoms by applying a score for these 5 symptoms. Some patients will never know that they have delayed gastric emptying except when their diabetologist has problems in adjusting the dose of insulin before meals. He found that there is erratic blood glucose level. He gave them for them insulin. He found the patient develop hypoglycemia. Because in gastroparesis, there is this matching between the absorption of food and the action of insulin. So this may make the doctor think that it is not the food, it is gastroparesis. And our other patients do not know they have diabetic gastroparesis until they are put on, on a glucagon-like peptide GLP-1 receptor agonist, as liraglutide, for example, because these agents, this class of drugs can exacerbate the symptoms of diabetic gastroparesis. So after the patient had prescribed this GLP-1 receptor agonist, he started to suffer from the gastroparesis. When I listen to this, I have to make a diagnosis. So to make a diagnosis of gastroparesis in the clinic, first, try to know if there is any etiologies to detect if it is diabetic gastroparesis. On examination, we will not find many signs. Epigastric pain may be, distended abdomen. However, I wanted to know that there is no gastric outlet obstruction. This can be done either by an endoscope or by radiography. And if I did by endoscope and I found that there is remnants of food in the stomach, this will aid me to be sure that there may be gastroparesis. So the patient complained, I do an endoscope to know there is no gastric outlet obstruction. If the patient refuses, I do barium meal or barium meal follow through. Then I will refer him to do a motility study. There are three ways to do this motility study: gastric scintigraphy, wireless capsule motility, and the breast test. But however, the gold standard is gastric scintigraphy of solid phase of a meal. So I will ask for this on my request. Query gastroparesis. The patient had the following symptoms. I do for him endoscopy and radiography. There is no gastric outlet. Please for gastric scintigraphy of solid phase of a meal. This is the gold standard for the diagnosis of gastroparesis. I stop first for 3 days all the drugs that are known to decrease the gastric emptying. If he is on anticholinergic, I stop it. If he is taking anti-diabetic agents like GLP-1 receptor agonist or pramlintide, I will stop them. Because as you know, pramlintide will lead to gastroparesis. Smoking and alcohol consumption has to be stopped. And if the blood sugar is more than 270, I will postpone the test. Because high blood sugar will lead to delay gastric emptying temporarily. So I have to take care of these precautions before I ask for the scintigraphy. Then a standard radio-labeled low-fat egg white sandwich is used as a test meal, and they read it at 0, 1, 2, 3, and 4 hours. And as we said before, if more than 10% of the isotope still in the stomach, I have delayed gastric emptying. They try to make grades mild, moderate, severe, but it doesn't matter because till now there is no correlation between the degree of gastroparesis and how much the severity of the symptoms. Some people may have mild gastroparesis, however severe symptoms, and vice versa. So now, clinically, these are the symptoms of gastroparesis. Diagnostically, I am sure this is gastroparesis. How to treat? The treatment approach, first thing, gastroparesis is not curable. This is the first thing that you have to tell to your patient. My role is what? The primary treatment goal is to improve the patient's quality of life through symptom management. Two ways, non-pharmacological approach and pharmacological approach. Non-pharmacological, first, If the patient is malnutrition, I will refer him to a dietitian in order to give him supplemental hydration and nutrition to help him to get rid of his malnutrition. And for patients who cannot ingest solid food, homogenized or liquid meals. If weight loss from malnutrition is predominant, enteral and parenteral feeding. In patients experiencing gastroparesis, there is the multidisciplinary team, and the dietitian is very important with that. Usually, they ask the patient to take small frequent meals. Usually, they ask him to avoid the spicy, acidic, and the fatty foods. My role here, or the diabetologist, to treat the cause. So I have to adjust as I can this uncontrolled diabetes. Because people with gastroparesis have a slower post-meal rise in blood glucose level in the delayed gastric emptying, may be changing the timing of insulin, prandial insulin, to be after meals instead of before meals. This may help. And in this study, as Professor Andrew showed us, continuous glucose monitoring, they try to know if we do continuous glucose monitoring, this will help us to control this gastroparesis. And when they assess in this study 45 patients with diabetes and gastroparesis, hemoglobin, glycated hemoglobin more than 8, they enrolled them for 24 weeks, and they do for them continuous subcutaneous insulin infusion. They found 5 results. The first, mild, moderate, and severe hypoglycemic events were comparable. Either we applied the continuous glucose monitoring or not. Second, the glycated hemoglobin dropped from 9.4 to 8.3. Symptom score decreased. Quality of life scores improved. And the volume of liquid nutrient material tolerated increased. This means that continuous glucose monitoring can help us to improve the quality of life for the patient with gastroparesis. If the diet is not working, if the control of the blood is not working, the last thing, I have to prescribe pharmacological therapy for them. Till now, I have antiemetic and the prokinetics. And only the prokinetics that have many studies on them, metocloropropamide and domperidone. All of us know the side effect of domperidone, the side effect of metocloropramide. Metocloropramide has, as all of us know, extrapyramidal manifestation, and it has a boxed warning for tardive dyskinesia and acute dystonia. And the domperidone, all of us know, increased the QT interval, prolonged it. So it is a must to do ECG before. And in gastroparesis, when they prescribe metocloropropamide or domperidone, it has to be prescribed 40 milligrams per day. This is a very high dose. So this is the tools. The new agents like mozapride, and there is no papers, a lot of paper about them. The third thing, erythromycin. This is a macrolide antibiotic and the motilin agonist. It can increase the motility, improve the motility in gastroparesis. Now, if the patient is hospitalized, I can give him injections, about 50 milligrams per day, 2 or 3 times per day. However, it is tolerated, it is not worked well, it has many side effects, so it is not recommended, and it has a limited use in the treatment of gastroparesis. At the end, some people may have upper abdominal pain. And we hear, very important to say, upper abdominal pain. It is not abdominal pain. Because upper abdominal pain, because this is the stomach. However, abdominal pain, this may be intestine, colon. Upper abdominal pain, although avoiding tricyclic is important in gastroparesis, they found that tricyclic antidepressant will help in this category of pain. And the patient, by prescribing for them small doses of tricyclic antidepressant, they will improve the glycemic control and improve their symptoms. And if not working, we can use gabapentin. Surgical approaches, this is a very late condition, and we do it according to the patient. If his quality of life is very worsened, the surgeon will choose one of these approaches. And thank you very much.